Hello. Let's talk a little bit about commingling and rural health clinics. Commingling is a difficult, fraught topic that makes many of us very nervous. It's a serious consideration because there is large financial risk involved with not doing it correctly or having a commingling problem. So let's dig in today and talk about what is commingling, how to avoid it, and what are the parameters. My name is Charles James. I'm President and CEO of North American Healthcare Management Services. Our company has been around since 1992, and we provide Rural Health Clinic FQHC billing services, cost reporting, program implementation, program support, 340B management, and other a la carte consulting services. So let's dig into commingling. Among the topics that we're going to discuss are some basic definitions. What are the considerations for our cost report? We'll start to look at some of the different kinds of commingling, like duplicate reimbursement and financial triage. We'll discuss and differentiate non-rural health clinic hours and carving out non-rural health clinic hours as distinguished from what non-rural health clinic services we can provide and how that's different and not a commingling consideration. A big commingling risk is our patient treatment areas and procedure rooms, and how do we integrate specialists without creating commingling problems. Merriam-Webster defines commingling as combining funds into a common fund or stock. Proceeds from a sale have been commingled with other funds. So I sell a stock. I'm an advisor, financial advisor. I sell some stock, and I commingle funds from your sale of stock with my sale of stock. Well, that would be a big no-no in the financial world, wouldn't it? Let's look at another definition. Combining things into one body. It's most often relative to funds and assets. When a fiduciary, a person entrusted with management of funds, other than his or her own, as a biller, and we don't take possession of any money as billing companies, but we have fiduciary responsibility to our clients because we manage that billing. We're managing those funds. So, entrusted with the management of funds other than his or her own, mixes trust money with that of others, the fiduciary is commingling funds and breaching his or her fiduciary duty. A member of a corporation's board of directors commingles funds when he or she mixes personal funds with the funds of the corporation, and an attorney who commingles his or her money with money belonging to a client, a major violation of ethical standards, right? So that is a more precise legalistic definition of commingling. Let's take a look at how Medicare feels about it. Remember, what is our encounter rate? It is our total allowable cost divided by our total number of patient visits, and productivity, payment limits, and other factors are considered in this calculation. So it's important to remember when we're talking about commingling, what is our rate? Well, our rate is representative of our patient cost, and our patient cost is a function of our total allowable cost and our total patient visits. We know these things from other sections of our Rural Health Clinic billing series. The AIR is set via the cost report. Provider-based clinics file their cost report as part of their hospital or parent entity. Cost must be appropriately allocated and tracked for RHC space and personnel. Really, provider FTEs need to be measured via formal time study, and we're measuring their time in the clinic available to see patients. Our medical director, physician, PA, nurse practitioner, nursing FTEs have a major impact on our cost reporting. And our lab expenses as non-RHC services must be allocated and reclassified appropriately. Our cost reporting software does all of does the lab expense reallocation kind of automatically. But remember, we're being really careful about how we're tracking costs for rate setting. Commingling in the Medicare Benefit Policy Manual, Section 100, refers to sharing RHC or FQHC space, sharing space, staff, supplies, equipment, or other resources with an on-site Medicare Part B or Medicaid fee-for-service practice operated by the same RHC, FQHC physicians or non-physician practitioners. So it's saying RHC space mixed with another Part B or Medicaid fee-service provider. So, now this is, I'm reading this because it's direct quote out of the Chapter 13, Medicare Benefit Policy Manual. RHCs, FQHCs must maintain and provide adequate cost data based on financial and statistical records that can be verified by auditors. Sounds pretty specific. We must identify and remove from allowable costs on the Medicare cost report all costs associated with the provision of non-RHC FQHC services such as equipment, supplies, facility overhead, and personnel. So we already are in that habit for our straight non-rural health clinic services. We can furnish other services outside the scope of our RHC and FQHC benefit, such as our lab, technical component diagnostic services. As long as we're authorized to furnish these services and they're covered under a separate Medicare benefit category. Look, it doesn't say the services can be billed separately. It says the services must be billed separately, not by the RHC or FQHC, which means not by our RHC or FQHC provider number, but under the appropriate A or B MAC using those payment rules. So what are our non-RHC services? Our non-RHC services are hospital services. Our providers are outside the rural health clinic. Those are by definition non-RHC services. Our lab, diagnostic testing, those are by RHC statute non-RHC services. We must carve those out and remove those non-RHC allowable costs from the cost report, including space, equipment. Again, I've already read that. These are our list of non-RHC services. Medicare excluded services, technical components, lab, DME, look at that, telehealth distance site services, group services are non-RHC, ambulance, prosthetic, body braces, services at certain other Medicare facilities, i.e. your hospital, and hospice services. So these non-rural health clinic services can be provided during rural health clinic hours, and it's not a commingling function. And you know why it's not a commingling issue? Is because it's by statute how we must do it. Hospital services, physician services at the hospital, must be billed to the MAC fee-for-service. If we're a CAW and we've opted for option 2 billing, our outpatient services are billed under the parent MAC. And our physician services at the hospital are reclassified out of the RHC costs on the cost report, and this is not commingling. On the option 2 billing, that outpatient services does not affect your rural health clinic claim. It affects the CAW's outpatient claim. It's not a rural health clinic claim. But regardless, hospital services are defined non-RHC services and can be billed during non-RHC hours, and it's not. Duplicate Medicare or Medicaid reimbursement is also commingling. And look at the parentheses here. Duplicate Medicare or Medicaid reimbursement includes situations where the RHC is unable to distinguish actual costs from those that are reimbursed on a fee-for-service basis. So remember about our cost accounting methods, and the MAC has the ability to determine if they're correct. if we have no method to distinguish actual costs from our fee-for-service, if we're just doing it, oh yeah, we're just have non-rural health clinic hours and we're just kind of doing that. Well, selectively choosing a higher or lower reimbursement rate and not being able to adequately account for your costs are both considered commingling, financial triage. We're getting into really difficult territory here. What constitutes duplicate Medicare reimbursement? Billing a rural health clinic service to Medicare Part B, physician fee schedule, fee for service, $1,500. Billing venipuncture. Remember, venipuncture is part of our encounter. Billing injections. Remember, we went through that list. That's why we went through the list. These are defined RHC services. That's what goes on our UB04. And if we're billing defined RHC services during RHC hours separately and to the Medicare physician fee schedule during rural health clinic hours, we are commingling. Period. Making decisions based on how the service is paid in a particular setting, delivering that service, i.e. what we just saw before, selectively choosing a higher or lower reimbursement rate based on the setting, is duplicate reimbursement, is financial triage, is commingling. Unbundling RHC professional services. We're going to talk about a treatment area here momentarily. That is duplicate Medicare reimbursement. It is commingling. It is a fraudulent bill. Venipuncture, as defined, as stated in the Medicare Benefit Policy Manual, Chapter 13, is part of our RHC encounter. We cannot carve that out and bill it to Medicare Part B fee-for-service. So if we're billing venipuncture fee-for-service, we're commingling. So expressly, MLN 8504, venipuncture is included in the all-inclusive rate when furnishing an RHC by the RHC practitioner. And you know what? If we want to get into tricky language about, well, we have a leased person in our rural health clinic and, we can have these distinction between who's a practitioner or who's not. Medicare is not going to read. Medicare does not do creative reading. So CMS, it says it's included in the all-inclusive rate, period. Leave it that way and you won't have any risk of commingling. That's what we're here to avoid, right? RHC hours. If an RHC or FQHC provider furnishes an RHC service, remember, servant supplies, incident 2, physician service, servant supplies, incident 2, nurse practitioner service, servant supplies, incident 2. If we have a defined RHC service rendered during RHC hours in the RHC, we've got to bill it RHC, FQHC. We can't bill it fee for service. It's got to be billed as an encounter, period. It's a defined RHC service during RHC hours, case closed. There is explicit reference to treatment areas, treatment rooms, procedure rooms in the Medicare Benefit Policy Manual, Chapter 13, Section 100 on commingling, where this language was not in the Medicare Benefit Policy Manual in years past. These interpretations evolve, and what may have been once allowed is no longer. The Medicare Benefit Policy Manual, the last several years, each update has contained this language to prohibit RHCs billing for outside professional services to Medicare Part B from an area outside or adjacent to the RHC. So we cannot have a treatment room in our RHC that we're carving out and we're creating a white line and saying that treatment room over there is non-RHC space and we're going to go over there and treat this patient and take this lesion off. We can't do that. Treatment space in the RHC, any services rendered during RHC hours have to be billed RHC. We cannot financially triage that patient and take them across the white line. The across the white line just needs to be rural health clinic space. We can't have a treatment room. The procedures done in our rural health clinic during rural health clinic hours are billed to rural health, period. We can't have an island of non-RHC professional services within our RHC space. RHC treatment space and patient care areas cannot be shared with non-RHC providers during RHC hours, even for non-RHC providers from the same organization. This is not to be confused with having non-RHC services such as lab and x-ray, but defined RHC services must be billed as RHC during RHC hours. It's that simple. Services furnished at times other than the RHC or FQHC posted hours of operations may not be billed to Medicare Part B if these services for that provider, if the provider's compensation is included in the cost report. So that's commingling. So if we're including that provider salary in our cost report to support our rate, we cannot also bill that same service fee for service. That's duplicate reimbursement. So no islands or treatment centers in our RHC anymore, no longer allowed. We cannot have an RHC provider on our cost report billing fee for service at the time. So physician, provider at the hospital. We have to carve out hospital time for our providers if they're at the hospital seeing patients. That time cannot be included in our cost report. As I mentioned, we can't take defined RHC services and split them out and bill them fee for service. That's a really important concern. Non-RHC services are not physician and incident 2 services, are not NP and incident 2 services, are not preventive service encounters. So we can't reasonably split an RHC service out to bill it non-RHC. It's just contrary to our advice. You may establish non-RHC hours and provide professional services that will not be billed as RHC, but we have to post that these are non-RHC hours. The entire RHC has to be non-RHC at the time. So it's not that room, that hallway, that side of the room, that side of the building. It's all or nothing. The whole clinic is non-RHC or the whole clinic is RHC. It's not by hall, it's not by exam room. It doesn't work that way. We've got to post our non-RHC hours on the door and notify patients that these are non-RHC hours. They won't know what that means, but we have to post that on our door and really need to notify your state agency as well as your accreditation organization if you're using one. So if you ask the state, they'll say absolutely. You have to notify them of non-RHC hours. You can set up non-RHC hours. That's doable. Ask yourself some questions before you do it. What's our objective? Is it because we're trying to get paid better under non-RHC? Of course, that's going to be a consideration, but is that the reason you're doing it? Is the carve-out are we carving out so we can bill incident 2 injections? That doesn't work. A lot of times the question is, well, I'm having specialists in, or I'm doing a lot of procedures. So my procedures I can't do during rural health clinic hours. It's a $350 charge. Well, the issue is we really need to look at what you'd be paid under fee-for-service. Your charge may be $350, but I'll bet the Medicare payment is below your rate. There's not much that we would do in the rural health clinic, especially if you're in a provider-based uncapped setting. There are not a lot of primary care services. They're really going to exceed that rate. There'll be some procedures, but systematically, we generally stay underneath the rate for that reimbursement. So we really have to ask, if you're trying to carve out procedures, the next thing to say is, are you really doing that many of them? A lot of times we think we're doing a ton of procedures. Oh man, I'm doing 10 a week. Well, it's really 10 a month. So we need to ask what we're going to do during non-rural health clinic hours. Maybe we're having group counseling sessions. That would be an appropriate non-RHC to carve out, or an RHC thing to carve out. Maybe you do want to do procedures. We have a lot of procedures that we do, and it's too much of a disruption in our daily schedule. So we're going to set up Wednesday afternoons for procedures, and Wednesday afternoons the entire rural health clinic is a non-rural health clinic, and everything that happens on Wednesday afternoons is fee-for-service. Now keep in mind, we've just taken 1/10 of our rate out of the cost report calculation. We're going to carve out one afternoon, so we are reducing our all-inclusive rate by doing that. So we really need to proceed cautiously when we're trying to establish non-rural health clinic hours, and ask a lot of questions about why, what's our actual volume, what's the objective, and is it financial triage. Payer contracts. I put a slide in about occupational health, and really occupational health is and can be considered a rural health clinic service. When you read rural health clinic service, it's taking medical history, making medical assessment, medical decision making, etc., etc. These are rural health services we're providing. So a lot of times we get fearful that if we have a special payer contract with a local employer or a specialty payer, that's somehow commingling. These are not commingling. These are really just like other payer contracts. So you're contracting, a local employer is contracting with your RHC to provide care to their employees on a specific fee schedule during RHC hours. Great. It's not commingling. There's no reason to set up a big non-RHC or some other service for those employees. It's a payer contract. Same with drug testing services. Same with DOT physical. Special other payer contracts. Now we get into particularly ticklish areas where maybe we're wanting to do some holistic or some non-FDA approved or aromatherapy or things like that. Well, I will reserve my personal opinion on those. But those cash treatments like that would not really be considered RHC services, would not have those during my rural health clinic hours. I think those are easily distinguishable from what we're talking about with these payer contracts with local employers and drug testing and that type of those types of activities. So payer contracts are fine. I would not be afraid of payer contracts in the context of commingling whatsoever. Let's talk about how we would use space. So that's often the biggest issue. Now here's the issue in this particular example. We had a weight loss clinic I'm going to go north, south, east, west on this, even though I don't think that quite aligns. Our weight loss clinic is over there, non-RHC on the west side of the clinic. We have a pharmacy and non-RHC on the east side of the clinic, and the center of the building is Rural Health Clinic, including our lab, file room, exam rooms, offices. Now, as you can see over there in that central hallway going really from east to west, traditionally prior to this location becoming a rural health clinic, the patients would use the central waiting room and cross rural health clinic space to get to the weight loss clinic, even though if you can see on that very western end there's an exit sign. There's a separate entrance and waiting room for the weight loss clinic. Well, here's the deal. non-RHC patients cannot have access to RHC patient care areas. So we had to close the hallway and we installed a door. The pharmacy was already sequestered. The non-RHC spaces looked like separate practices. The weight loss patients had to be redirected to the other door to check in at the appropriate place. We could not continue crossing Rural Health Clinic space and checking weight loss clinic patients in the RHC waiting room. So we built an interior door where that file room is and over by the pharmacy to prevent access to the RHC from those areas during RHC hours. Let's talk about waiting rooms and reception areas. We can share waiting rooms and reception areas. Certainly there would be infection control considerations and there would be HIPAA considerations. If we're having cardiology share a waiting room with our RHC, how are we keeping our sick RHC patients away from our cardiology patients? So regardless, we can share waiting rooms, telephones, receptionists, check-in, check-out areas with another entity, but we must maintain accurate records to ensure that all costs put on the Medicare cost report or for the RHC only, and we're reallocating the rest of that out. So if we have a shared waiting room, how would we do that? There are any number of mechanisms that our accountants can come up to allocate space for a shared waiting room and reception area. We could talk about services, we could talk about square footage, we could talk about staff. We can talk about a lot of different allocation methods to do that. We can share space, we just have to make sure we're keeping clean records and we have a sound and documented allocation methodology. That's the really important piece. We have a sound allocation methodology that we can prove with documentation. If the RHC is located in the same building with another entity, such as an unaffiliated medical practice, X-ray and lab facility, dental clinic, emergency room, RHC space must be clearly defined. If the RHC or FQHC leases space to another entity, all of those costs associated with the lease space must be carved out. So if we have outside providers, we have to make sure those spaces are clearly defined, and we're not just talking here by signage. We're talking by square feet. We're talking by cost report allocation, clearly defined. Very important. As such, if we're having visiting specialists in our RHC, what are some of the ways that we can deal with that? The best way is just have the specialist bill as part of the RHC. Specialty services work very well as long as we maintain 51% primary care as measured by total provider hours. 51% primary care. We can have all the specialists we want to in our Rural Health Clinic and they can bill as Rural Health Clinic providers. No carve out, we don't have to sequester services, easy peasy. If we have somebody renting space, they bring their own staff, they do their own billing, we're carving out that space, we're allocating overhead out of the cost report, we've got to put up signage that those outside providers are not some of our providers, but they're visiting. We can't just have specialists coming into our Rural Health Clinic and leasing space without some kind of signage on that. We can't do it. So the appropriate way to structure a specialty clinic and an RHC in the same space really is fairly strict. The RHC, we're sharing waiting room, reception areas with our specialty providers, even if they're from the same organization. Our patient treatment areas have to be totally separate from one another. We cannot have patient treatment areas that share space with a specialty non-RHC provider. We can't have it. That is commingling. I would rather that each clinic have their own patient registration and check-in, check-out personnel indicated by signage. That way we have less of a cost allocation and tracking to make. The clinics must function as separate practices other than their shared waiting room and reception space. We have accurately tracked costs and an allocation method documented. That's the only way to do it. Here's a good example, and the floor plan is hard to read, but the colors give us the indication that we need. So again, going north, south, east, and west, the main waiting area for this particular space is up in the north central region between the green Suite 100 Rural Health Clinic and the yellow West 102 non-RHC. So everyone shares that waiting room, and then we have our behavioral health folks down in the southwest corner of the building, and you can see the white hallway that goes around that northwest corner, around the green RHC space. That's where patients walk from the waiting room to the non-RHC space. So no shared space. All of the doorways between all of these spaces are closed. We share a waiting room. We have an easy cost allocation method here, and once the patients are called, they go to the correct area of their clinic. So this is how we would have to do an RHC and specialty clinic in the same four walls. They've got to look like different practices if they're not going to be billed as RHC. At the end of the commingling section in Medicare Benefit Policy Manual, it says that the AB has the MAC, has the authority to determine acceptable accounting methods for cost allocation. So here's what CMS is saying. The MAC has all power in this. There's basically no arguing with the MAC. If they say it's an acceptable accounting method for allocating these costs, then it's appropriate, and if they say it's not, then it's not. And look at this, in italics. In some situations, a practitioner's employment agreement will provide a useful tool. So we got to be sure that our employment agreements are keeping our RHC and our non-RHC straight. And if we're being compensated out of the RHC, we're not billing those services fee for service. So commingling is a scary topic, but it's a very serious topic because we can't mess with it. You'll get some major sanctions, and your rural health clinic license and probably your hospital license would be jeopardized by violating these commingling requirements. So nothing to take lightly. We have some draft guidance on co-located space. This guidance has been put on hold. This guidance has not been implemented because of the public health emergency. So it does, however, give us an insight into CMS thinking on what they were about to enact before the public health emergency took effect. We can be co-located with other hospitals or other healthcare entities in co-located space. This is actually relative to provider-based space. We can be located on the same campus or in the same building. We can be co-located in its entirety, or certain parts of the hospital can be co-located. Outpatient departments of one hospital are located on the same campus or in the same building as another, or located next to a Medicare certified, look at that, we get an RHC or FQHC right there in the guidance. So they were talking about co-location of rural health clinics in hospital provider-based space, and the fact that it has to be maintained separately was the point of all this. It's expected the hospital have defined and distinct spaces of operation for which it controls at all times. So that includes designated patient care areas, infection control, protection of patients, and HIPAA violations. So Medicare is looking at these shared spaces in terms of HIPAA violations and infection control, and in terms of public versus non-public paths of travel. So perhaps we have a public path of travel through our rural health clinic, and of course, that's not going to work. Both entities would have to be individually responsible for their own. This includes our public and non-public paths of travel. So we have considerations for public spaces and paths of travel, including public lobbies, waiting rooms, reception areas, etc. So again, this last guidance was not implemented, but is provided as an insight into CMS space sharing thinking. So again, let's summarize. Commingling. You cannot share space. You cannot share patient care space between an RHC and a Medicare Part B provider. You can set up rural health hours versus non-rural health clinic hours and provide services during non-rural health clinic hours, but it's the whole rural health clinic or none of the rural health clinic. It's not part of the rural health clinic. It can't be just those 3 exam rooms or that procedure room. Those are not adequate carve-outs anymore. So RHC hours and non-RHC hours, all or nothing, period. The best thing to do, integrate those specialists into the RHC, advertise specialty services, and then anything that needs to be out of the RHC goes to hospital outpatient or hospital inpatient, of course. Keep the services appropriate for the rural health clinic in the rural health clinic, and anything that needs to go should go. And then we don't have all of these commingling considerations in the first place. And just remember, these concerns evolve. The Medicare Benefit Policy Manual has changed significantly over the past 5 years. And over the past 10 years, I would say this is probably one of the biggest changes, is they've really tightened all of the commingling rules and restrictions. So they're just really nothing to take lightly or not take deadly seriously. So now let's talk about Medicaid and a couple of different Medicaid agencies. All of the language that I've used is out of the Medicare Benefit Policy Manual. Some is out of the Medicare Claims Processing Manual. But these are the references. These are my Bible for everything we do with rural health clinics. But Section 100, the commingling section, is in Medicare Benefit Policy Manual, Chapter 13. As I mentioned, it has evolved quite a bit over the years, so please make sure and check that out. And this is me. Here's where I can be reached. We can be reached. If you have any questions or if you'd like to inquire about North American, please don't hesitate to call or email. Thank you very much.